Thanks, Rod, and thanks, Jens, for organizing the course. And I know. Thank you. You guys are great partners. I've just been lucky to be here the last now almost 6 years. So, and of course, always thanks to the SSF crew. Ben, thank you, and Linda and Alexis and everybody here. So I've been doing this now for probably 10 years, and Larry Lenke will say that he has not done an anterior approach in that amount of time, and I respect that. And I think this is kind of an ancillary maybe to that idea. So I like the plan of doing everything you can posteriorly. If you finish everything from the back, you don't need an anterior approach. But if you don't finish everything from the back, you can easily come back in a delayed fashion 4-6 weeks later when the patient is nutritionally replete, they're recovered pain-wise, and you do a small anterior procedure, and it doesn't disrupt their recovery. And I think the complication rate is reduced as opposed to trying to do anterior first and then within the week or a few days later doing the posterior approach. So I think combining two approaches close together is more morbidity perhaps than separating them. So to review, and why do we like anterior surgery to begin with, and why do we like it first, right? Historically, deformity surgery was always done with anterior stage first, with the idea that you could get better deformity correction by doing it in that way. And that was true back in the day when our techniques and our implants were not what they are now. Back in the day when Dr. Kostwick and David Bradford were doing this kind of work, they were using implants that just didn't have the strength and the techniques didn't have the ability to correct deformity posteriorly that we now do. So the notion of increased correction is, I think, now kind of gone by the wayside, or really is unnecessary. It does increase the fusion rate, perhaps. I think you've got a much bigger fusion bed, right, and compression loading. That's a very big advantage, and I think that still remains. And now we can do anterior approaches with a limited access, and that really has been a game changer, and I think will continue to be. So there are, though, potential negatives to doing anterior surgery first. First of all, it's more surgery in a single setting. So we know there's solid data repeated in multiple settings that show that there's a higher complication rate if we stage surgery close together. And I will argue, and further in the talk, there is simply no role for isolated anterior surgery in adult spinal deformity, in my opinion. In pediatric deformity, sure, I get it. In adult deformity, I don't think there really is a role. And the biggest disadvantage, I think, of doing anterior first is that it really obligates us to complete the posterior stage early. You can't let the patient mobilize and discharge and come back at a later stage when they're walking around with anterior interbody devices without stabilization. As I just said, I think increased correction is no longer an issue. We have all kinds of osteotomy techniques, and not represented on this slide, of course, is the anterior column release. But if you look at the bottom there, this is a procedure that really Rod and Jens have perfected. It's something I have done for a number of years as well, but they've really enhanced it with expandable cages now. But I called that a Smith-Peterson osteotomy plus TLIF. They like to call that then intradiscal osteotomy, and I think we'll hear more about that when Dr. Chapman gives his talk. So I would propose there's a paradigm shift. We really no longer need to do anterior surgery first, and posterior only. If we can do it, it's faster, it's safer, it's equally effective. But if the posterior surgery is not completed, is not sufficient, we can come back on a delayed basis and do the anterior procedure, and I think with a much less, a much smaller complication rate. So anterior surgery, in my opinion, should only be used when it truly adds value, and in my opinion, these are the cases where you might go in planning a posterior surgery with a plan for a delayed second stage procedure. So that includes a setting where we're going to have to revise a prior TLIF or PLIF, working around scarred nerve roots, I think not my favorite thing to do. a compromised posterior fusion bed. If you're not confident you're going to get a posterior fusion, you need to somehow get an anterior fusion. Shortening the posterior operation, again, I think is an advantage, and sometimes that's an intraoperative decision, but if blood loss is creeping up, if the duration of the surgery is getting long, I think a lot of times it makes sense to close the posterior operation down, instrument, stabilize, get your correction, and come back to finish the inner bodies at a later time. There are, in my opinion, and we just had one the other day, anterior gaps that are too big to fill safely or effectively from the back. In that case, I'm going to stabilize things, come back, and put a robust anterior interbody device in. And I still think that 5.1 is one area that we may want to routinely do an ALIF, or certainly often do an ALIF if you've got a 5.1 disc that's plump and quite lordotic. I still think we get a better fill from the front, and certainly a lot of surgeons make that argument. So how do you achieve sufficient correction of deformity posteriorly? You need to do aggressive facet resections. I think that's a key element. I think now we have larger diameter and stiffer rods. I think watch that space. I think we're going to have now even stiffer rods using new alloys that may not be larger, but will definitely be stiffer and offer a stronger ability to correct deformity. Preoperative planning, knowing what you get out of a given osteotomy so that you can plan your procedure, and that's also something now that it can be data-driven for individual surgeons using preoperative planning and then postoperative measurements. And then getting your grafts anteriorly, if you're doing T-lifts, that allows you to correct the hypolordosis and really gain greater lordosis using the graft as a fulcrum. And then I think the power of numbers, so getting correction at every level, even when you're doing a big, maybe 3-column osteotomy, make sure you're getting correction at other levels as well. So this is what I was calling the Smith-Peterson osteotomy plus T-lift, what my partners call interdiscal osteotomy. I did a measurement. I never got this published, but I did look at a number of cases, I guess about 15 cases that I'd done with this technique, and we were getting about 14 degrees per level. So certainly this increases the amount of correction you get over a simple Smith-Peterson osteotomy or posterior column osteotomy. And this is an example from a number of years ago of that technique in a gentleman. You can see he's very flat, hypolordotic, or even kyphotic in the lumbar spine. And we did multi-level T-lifts with aggressive posterior facet resections, and we're able to get him nicely corrected in the coronal plane and in the sagittal plane. So how do you avoid pseudoarthrosis if we're only going to do a posterior approach? I'm a big fan of osteobiologics. These are off-label uses of BMP, but I do use BMP in every fusion, particularly multi-level fusions in adults. I think it's almost essential. You can decide what dosage you want to use. I tend to use 2 large kits for a T10 to pelvis fusion and 3 large if we're going to upper thoracic. I use 1 small sponge at every interbody level around the interbody graft. As I said, you maybe do include an ALIF at 5.1, depending on how tall and lordotic that disc is. I like to put an interbody at every laminectomized level. I think the bone loss with the laminectomy reduces the chance of fusion there. Increasing rod diameter to 6.0, and again, maybe that number may change as we have new alloys on the market to utilize. I use bilateral pelvic fixation, and now for almost every deformity, I'm using quad rods, so dual pelvic screw fixation with the outrigger rods extending across the lumbar construct. And then, if needed, we're going to use a second stage anterior procedure to fill in gaps. So here's the 3-column osteotomy, pedicle subtraction osteotomy. That is, I think it's key to realize that you need to have an interbody above and below the pedicle subtraction osteotomy. You're taking the facets off, so even if they had a posterior column fusion, if that disc below the osteotomy remains, you've got to fill that in either from the back or from the front in order to reestablish fusion across the osteotomy site. Did I say that clearly, Nathan? Yes, good, thank you. All right, and here's an example. Actually, this is a case I did with Nathan not so long ago. So this is a woman who came up having had robust fusion with multiple inner bodies first and then a posterior construct, but unfortunately in a rather poor alignment, both in coronal and sagittal plane. You can see just way off, and this is her surgical history prior to coming to our office. And she was also, osteoporotic, was on Forteo, had been for about a year prior. And we actually did a 2-level PSO, both asymmetric PSOs, and then came back to do the anterior to psoas just above the discectomy at the L2 level. So you can see this is the correction we got with that. And here's the inner body we did on a delayed basis about 4 to 6 weeks after that at the L1-2 level. And then at that point, we removed her pain pump. So that's often an ancillary part of these procedures as well, either the stimulator or the pain pump removal. So, and so far so good. She's only about a couple months out at this point. Here's another recent case that I revised of my own work. This was a woman I operated on now about 4 years ago, and at that time was using just a 3-rod construct, and she seemed to do quite well. We had 3 inner bodies, an A-lift at 5.1, and then T-lifts at 3.4 and 4.5, but unfortunately, she came up with a non-union at the 3.4 level, as you can see here, and recurred some of her deformity and certainly was in a lot of pain. She was delayed because of COVID with her reconstruction, but finally about 6 months ago we were able to get in and get her taken care of, and we did her in 1 day with a revision of the posterior hardware, and then in the same setting turned her lateral and performed the OLIF at L3-4 there, and so far she's had a nice outcome from that. And this is a more typical quad rod construct that I'm using today, and you can see we didn't disrupt the upper instrumentation here. And that's something I really, if I can, I like to do. That's another complication avoidance that if you don't disturb the proximal junction, you really almost never get proximal junctional failure. So if they've got a fusion and they haven't had difficulty above, I really like to leave that implant in place, not disturb it. And that's an ISSG data shows that we don't see further fractures because by then the surrounding tissues and bone have remodeled and healed, and so there's very little chance of a fracture occurring. This is a woman I operated on a number of years ago down in Portland, really a delightful lady who had hydrocephalus as a child and suffered developmental delay with a large deformity that had been treated elsewhere without solid fusion, as you can tell. She was just a fixture of her community, really, and a large deformity here with tenting of the skin by that long posterior rod. So this was another variation of multi-rod construct. We put 2 primary rods, and then I ran a 3rd rod as kind of a long cross connector between the 2 rods, the 2 primary rods, and we did essentially a VCR and came back and completed anterior interbody fusions with a large femoral strut or tibial strut at the L2 vertebrectomy site. So limited access anterior surgery, I do love it. I am a fan. It saves posterior complications. Those would be a reduction in OR time, a reduction in blood loss, and I think it reduces the need to manipulate discs around nerve roots and therefore maybe safer from a neurologic standpoint. And again, the lateral can be done as a delayed second stage rather than early on in the patient's recovery. Here's another example of that. There's a woman that I treated a number of years ago. You can see quite kyphotic, and again, you can readily do the ALIF or the lateral post after the instrumentation. I think that's also a myth. There's this argument once the instrumentation is in place that you can't safely or effectively do the inner body. That is not true. Now, you aren't going to get deformity correction, but you've already got that, and you can absolutely access the disc, perform an adequate discectomy, and get a nice tall graft or cage into that space. And this was a woman, actually, the ALL ruptured as we were doing her posterior procedure. You can see on the left long film, there's a small interbody bone dowel there kind of floating in the breeze. And so we went in laterally and took that out and fitted her with a hyperlordotic cage. And she did quite nicely from this operation. Finally, I'll finish with the thought that standalone multi-level X-lifts, O-lifts, or anterior to psoas, whatever acronym you want to use. That's just a bad idea in my opinion. And this was a publication touting that approach, and actually appears that the fusion has healed, but I would argue clearly not with significant deformity correction. Here's an example of why I think this is a bad idea out of my own practice. A woman who came in having had a 3-level T-lift, and I know this can be done as an outpatient. I know a lot of surgeons have outpatient centers that they may have financial investment in, but I would argue that we should always tailor our surgeries and our surgical plans to what's best for the patient, not what's best for our investors or ourselves. And this was the revision of that was required, given that none of the 3 levels had healed. So in conclusion, preoperative planning is critical. The key goals of a solid fusion and adequate alignment can typically be accomplished with a posterior approach, but in some cases we may want to plan for a delayed anterior approach, and in some cases we may want to make an interoperative decision to finish what we need to do from the back and come back on a delayed basis and complete the anterior approaches. And as always, I think we need to resist adoption of new techniques based on intuitive sense of whether it makes sense, and ultimately based on data to prove that it's effective. So, and I'd like to close with this. This was over in Ghana with Ohene Babawachi a number of years ago, and they allow you to go up and touch the alligators there. And the quip I use is, if you wrestle with alligators, you are occasionally going to get bit. And certainly I've been bit a number of times over the course of my career. And those are my kids. And so thanks to all of you, and thanks to my family.
Awesome. Thanks, Bob. Appreciate it. So